more than anything, more above all these things, he's a great human being. He's a great friend to everybody, and he has a human touch to the patient, and he believes in compassion and charity. A very humble man. All these things probably people like me should have adopt. With these few remarks, now I request our speaker, today's speaker, Dr. K. Nageswar Garu, to start his presentation. I thank all the participants for coming on time, but my sincere apologies for the delay due to some technical issues. Thank you. Over to Dr. Nageswar Garu.
Dr. Nageswar, over to you, sir. We'll stop at around 8:45. Opportune time, you please let us know. Dr. Ajay Mohan will be the co-host today, and he'll have a look at the chat box and compile the questions, and he'll summarize the questions so far to you. Over to you, Dr. Nageswar, and wish everybody a happy learning. We're sorry that we can accommodate only 100 and it's already full even before we start. The current session is live on YouTube. For those of your friends who are not able to be part of the session right now, you can see the session on YouTube. You can even type your questions there, and we'll be coordinating that and try to get answers from Dr. Nageswar. Sir, it's over to you. Thank you.
Sir, thank you very much. It's a really great pleasure indeed. IAP is very close to my heart, and I always feel IAP, I am one of the member of your family, big family in Hyderabad as well as in Telangana. It is my great honor indeed to be part of your teaching schedule, and I believe that a lot of students are there, and also I am quite surprised that senior people, I am not that senior like everybody is there, C.N. Reddy sir, Bhaskar Rao sir, Bhaskar sir, everybody. It's my honor, great honor. Without wasting time, I am going to discuss certain really important aspects of recent advances in management of congestive heart failure. So these are my disclosures. These are on with the patent, and I am in the process of developing a second product called neonatal stent kit. So if you look at broadly, the situation when the heart is incapable of maintaining cardiac output, that is the definition of heart failure. Whenever the heart fails, not able to pump the blood which is needed to the body. There are various important definitions which students' perspective, they should remember this at any cost. A circulatory failure denotes an abnormal blood flow through the cardiovascular circulation that doesn't perfuse to the body or tissues. Heart failure refers to abnormal cardiac pumping of blood with or without abnormal heart muscle. Here, the muscle may be normal, muscle may be abnormal, cardiac function may be normal, cardiac function may be abnormal. Whereas myocardial failure, this is the definition for the myocarditis and cardiomyopathy. Abnormal cardiac pumping, here the contractility is the problem leading to the heart failure. You have variety of reasons for the heart failure. Essentially, the commonest cause for heart failure in children are heart failure due to structural problems like ventricular septal defect, mitral regurgitation, large PDA, AP window, aortic stenosis with ventricular dysfunction. All this contribute to heart failure, and these are all potentially treatable conditions. Whereas the myocardial contractility problem like myocarditis, either calcium problem or tachycardia cardiomyopathy or metabolic disorder, all these are going to give myocardial pump failure. So today I am predominantly going to show you several examples which includes the myocardial failure issue. What are the main mediators of the cardiac output? To have the good cardiac output, either at a resting state or during exertion, that is typically exercise, the heart rate and the stroke volume. Heart rate will be increased, the cardiac contractility will be increased, so that amount of blood from the ventricle will be ejected will be more to compensate the metabolic demands. The important parameters which are going to influence your stroke volume are preload, that is the blood which is coming to the heart, either it is to be right side or left side. Afterload, the ventricle which is pumping against resistance. like a right ventricle which is pumping into the lungs. If there is acute pulmonary hypertension due to so many reasons, like your pulmonary edema or your respiratory tract infection, bronchiolitis. So all this can cause acute afterload impairment, contractility, any virus, any toxins, any invasion leading to the damage of the sarcomeres. Why the heart failure is different compared to the adults? This is a very important aspect. If you look at the myocardium of the infant and children, the amount of contractile mass in neonate and infant and children are varying, whereas adult, which is totally matured. So in a neonatal or infantile myocardium, the amount of sarcomere, the length of the sarcomere, the amount of stretch of the sarcomere are significantly less. That's why they are more prone for heart failure with any insult or injury. The ventricular endostolic volumes and reserves, the left ventricle can dilate to some extent in children, or right ventricle can dilate to some extent. So the amount of ventricular reserve is less. Similarly, heart rate reserve, already their heart rate is working above 90, 100, 120 various ages, whereas adult, for an example, we have 72 heart rate. So we have a margin to increase to 120 heart rate whenever there is a problem, either due to fever or exertion or any cardiomyopathy, whatever it is. Whereas in children, that mechanisms are failed and which has got a very low margin. That's why they develop a heart failure very fast. So this is the sarcomere length over the with the ages, and you can see in case of infants, the amount of length, contractility of thick filament and thin filament, both thin filament are very, very less. The amount of stretch is less. That's why they develop a heart failure much earlier. So far, what we know is heart failure in children is a serious problem. There are so many etiologies, but symptoms are unspecific, and a lot of neurohumoral molecular abnormalities play a critical role. And therapy is predominantly loop diuretics, some kind of inotropes and fluids. What we don't know or what we are going to know. Cardiac function assessment includes a cardiac synchrony. Whenever there is a bundle branch block, it is going to be a serious issue. The therapy is predominantly not only diuretics, fluid restriction, it is vasodilator therapy and beta blockers. And how to adjust the diuretics and other modality of treatments which we are going to discuss. Now you see this particular slide. This is very, very interesting how we are actually embarked into the extreme cases. This is a 21 years, 28 weeks gestation referred with the high drops. Already 2 siblings had got some problems. Now you can see lot of pericardial effusion in fetus. So eye drops means heart failure. If you look at carefully here, this is the calcification of pulmonary artery, calcification of aorta. This is called as a fetal arterial calcification syndrome. So first baby, when we saw, we are not aware of this association of genetic anomaly, and we actually, they presented at mid gestation and we continued, and baby died immediately after that. So subsequent cases, we have done whole genome axon, and we found that axon 6 of ENPP1 gene is the problem for this, and prognosis is very poor, and this is the malignant kind of a problem. So if you come to know at 18 to 22 weeks of gestation age with this kind of problem, you will be in a position to counsel them. You can advise that donor ova or donor spermatozoa for the fertilization, and you can modify their family life. So that is one typical example which I thought I will share with you, how the genetic clinics are going to change our practice in the near future. Heart failure with a normal ventricular function, typically like VST, PDA, AP window, or cyanotic heart disease like a total anomalous pulmonary venous return, trunk, single ventricle, all these will have heart failure and potentially can be treated by either surgical or transcatheter technique. So these conditions, when we diagnose, we predominantly use a diuretic therapy and send them for surgery as early as possible, typically between 6 weeks to 3 months age group itself will treat them. Whereas certain heart failure with a normal cardiac contractility like arteriovenous malformation, beriberi, and diastolic dysfunction due to EFE, all these are going to be potentially benefited by various modalities of treatment. Similarly, heart failure due to ventricular dysfunction, obstructive diseases like coarctation, critical aortic pulmonary stenosis, all these can be treated either with the balloon transcatheter method or surgically. Whereas cardiomyopathy, pulmonary hypertension, right heart failure, tachycardia, cardiomyopathy, metabolic, these are the important conditions where from the pediatrician point of view, they often get confused to treat, whether to evaluate or not to do. These are all various issues which we come across. Essentially, above 7 years of age group, we classify the heart failure based on New York Heart Association classification. But in children with heart failure, this classification doesn't hold anymore. That's why now worldwide now switched over to WHO modified RAS classification. In this predominantly tachypnea and feeding difficulties are added. Heart failure 1, 2 can be easily managed with the diuretics and feeding adjustments, whereas heart failure 3, class 3 and 4, they need multiple medications, and probably we have to address the specific problem. If it is a structural issue, if it is a non-structural issue, we have to add additional modalities of treatment. So I want you to focus some of these issues here, which I'm going to show you. All we used to think, even myself, till 2010, heart failure in pediatric group is very malignant and it is going to give very poor prognosis and depressing results. That's why we used to counsel them a rule of 33. That means when they develop myocarditis or cardiomyopathy, 33% used to survive, 33% used to develop chronic cardiomyopathy, 33% used to die themselves. But in the present setting, it is not true. 67% are surviving and they are going to have the normal heart. You look at this, in 2008, we actually started treating one cardiomyopathy patient followed by the viral myocarditis, and we followed over the period of time, and we have a ventricular function which became 22 to 64% with the conventional modality of treatment of diuretics, ACE inhibitors, and beta blockers. Various symptoms which confuse all of us. Predominantly, it will cause respiratory distress, and the X-ray will show pulmonary edema and often complicated by the viral pneumonia. So we are going to treat them most of the cases as acute lower respiratory tract infection. So that is the commonest presentation. But how to suspect that? Yes, disproportionate enlargement of the heart, disproportionate enlargement of the liver. Even you give oxygen, tachypnea doesn't improve. And unusual expiration, and there is excessive perspiration, sweating, and there will be grunting. These are the important clinical signs which you actually tend to see that it may give some idea about that it may be myocarditis or something. But believe me, sometimes when you auscultate, the respiratory sound and tachycardia will confuse you. But the presence of gallop, that is tug, 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 or harsh sounds when you get, that is going to be again a typical feature of acute myocarditis. So the present modalities of treatment, which is more than 66% will recover and 10% will have cardiomyopathy. Unfortunately, still we are going to have significant amount of patients who are going to die. So when you are counseling any case of cardiomyopathy or myocarditis admitted in your ICU, please tell that prognosis is still guarded, but there are some chances of survival of around 60% and never give prognosis bad of 100% in these patients. So you see this, the ECG, which typically you see when you have myocarditis or acute cardiomyopathy like picture, a typical low voltages and ST elevations you will see. And if you wait for 1-2 days, the ST elevations will subside and there will be development of the T wave, which will be inverted. These are all the progressive changes of a viral myopericarditis. So how do you prognosticate these patients? If you have LV ejection fraction less than 20% with intracardiac thrombi, presence of severe mitral regurgitation, any myocarditis patient, if you auscultate pansystolic murmur, it is not a good sign. They will have a poor prognostic sign. Persistent low voltage. See previous patient, the low voltages here improved here. That means it's a good prognosis. If we have persistent low voltages, the QRS is broad, very broad, and presence of ventricular arrhythmias in ICU, and even on inotropes, the blood pressure is not maintained properly. You give adrenaline, you give all sort of inotropes, BP is not maintained properly. That means the prognosis is poor. People studied on BNP levels. If BNP goes very high in thousands, that again indicates that a prognosis is somewhat guarded. So this is typical of a heart failure with respiratory infection and plethora and cardiomegaly suggestive of a post-Rakesh patient. Here, heart failure, cardiomyopathy, the cardiomegaly, left atrial enlargement, and pulmonary venous hypertension suggestive of predominantly it may be due to viral myocarditis or cardiomyopathy. So what influence our clinical practice? Our clinical practice is predominantly influenced by the response to the pharmacotherapy and identification of the conduction disturbances. And now recent advancement of heart failure surgeries, ventricular assist device, transplantation, genetic clinic, all these are making the patient better outcome. So all students should have knowledge about our Guyton in physiology days. What is the Frank-Starling law? This is very, very important. In a normal heart, if you go on giving fluid in a low volume situation, the heart will dilate. The ventricular endostolic volume will be increased. Ventricular endostolic pressure will be increased. Myocardial sarcomere stretch will be more, so that the forward flow, the cardiac output will be increased. Whereas in failed heart, a myocardial muscle which is damaged, whatever amount you give, it will not stretch. It will be back flow. That means when you give fluid in the case of right heart failure, liver will be further enlarged, iris will be dilated, or in the left heart side, they will develop a cough and saturation will be fallen because of the increased pulmonary edema. So when a child comes with myocardial failure, various mechanisms like atrial ventricular dilations, reduced renal perfusion, and increased ANP, and renin angiotensin activation system will be more, and sodium reabsorption mechanisms will be failed, then heart failure will become more decompensated in this. So if you look at the treatment modalities over the period of time, initially people predicted and hypothesized and worked on cardiorenal model in late 1940s to till 1960s. That's why predominantly diuretics and digoxin worked very well. From 1960 to 1990, vasodilators and inotropes played a major role because people worked on hemodynamic models, because pressure transducer system, everything was available. All people started doing the ventricular volume, pressure volume loop curves, and then study the vasodilator response. Whereas the present neurohumoral mechanisms studied very well. That's why people use a lot of AC inhibitors, beta blockers, and aldosterone inhibitors. So this is the change over the period of time, how it happened. Our goals of treatment are relief of pulmonary and systemic congestion, predominantly diuretics, and reducing the load to the heart. That means SVR, PVR, so that the muscle will be rested, will have some kind of more contractile power, more relaxation, so that vasodilation will reduce the PVR and SVR in the respective ventricles, so that cardiac index will be increased. Whereas the inotropes will increase this excitability of the myocardium, and other areas of medications are going to play a major role, which I'm going to discuss with you. So when you have a kind of a heart failure, you need to understand the mechanism and then treat them. Like VST, there's no other way of medical management in less than 3 months of age, when you more than 3 months of age, when you have large VST, other than surgical closure. Similarly, total anomalous pulmonary venous return, all kappa, all should go for surgery, and your medications are going to give a bridge, a stopgap phenomena. Whereas some conditions which are very, very important, like myocarditis, other non-structural problems, need a lot of medications like preload reduction, diuretics, afterload reduction, ACE inhibitors, and vasodilators, Milrinone, sympathetic inhibitors like beta blockers, cardiac remodeling drugs, mineralocorticoids, and inotropic medications. So typically you can see this. This is the baby coming from Nalgonda. This is not new. Everybody, this is, I'm showing this particular case the second time. Last time I have shown in Karimnagar. So this baby came with respiratory distress, tachypnea, tachycardia, liver is big. So from Nalgonda, I think you can take some questions also here. I am not seeing chat box. I am just opening my chat box actually. Yeah. So some students can write the. So this is acute dilatation, acute right heart dilatation, severe TR, right ventricle is dilated, dysfunctional compared to the left ventricle. You can see that left ventricle is vigorously contracting, right ventricle is not contracting. This is an exclusively breastfed baby is the clinical clue here. So, and also baby is coming from the Nalgonda area. So what we have done, we have just given a medication. Believe me, this is 2 hours after the medication, not immediately. 2 hours after the medication, we give thiamine infusion, which is freely available, and you see the values. You see the thiamine values of 2.77 in the baby and 4.52 in the mother, in the baby. Mother 2.77. A poorly, predominantly they eat rice. That is the problem. So why it happens? See, thiamine is very important from lactate to pyruvate, and pyruvate is going to be converted into acetyl-CoA. So lactate to pyruvate, you have lactate dehydrogenase, and pyruvate dehydrogenase uses thiamine here. If you don't have thiamine, this pathway will be broken, and which is not going to be useful even in Krebs cycle, along with alpha-ketoglucarate dehydrogenase. So what will happen? The pyruvate will not be converted into acetyl-CoA. It will be converted into lactate, acidosis, and then vasomotor depression will be there, and peripheral vasodilatation leading to high cardiac output state. High cardiac output state, then you will have high cardiac output and PAH will be down. Sir, are you asking me to stop? Is it the...
Sir, if you want to proceed for another 5 or 10 minutes, you can.
I think I would like to proceed another 5 minutes and then we can see.
Yeah, yes, sir. So, if you can proceed for another 5 minutes, we can give a break and we'll go for the questions.
Conventional modality of treatment are fluid challenge, position, nutrition, sedation, treatment of anemia, and infection. So this is the traditional method people used to keep, but it's, believe me, practically impossible. But this method can be given to the infants with either structural or non-structural problems, continuous infusion of the feeding. This is going to be very useful, or nasoduodenal feeds, which we adopted. And you have to adjust it very, very significantly. So principles of management, fluid, diuretics, and inotropes and vasodilators are going to play a major role. So diuretics reduces the fluid load, vasodilators reduces the afterload so that SVR will be reduced and inotropes play a major role. So we have to balance using these medications between vasoconstriction and vasodilatation. Suppose you have a patient where already the mean blood pressure is less than 35, straight away going to start Milrinone is going to further worsen the situation. So further hypertension will cause renal compromise and low cardiac output, and again the patient is going to die. So that's the reason a physician should balance between inotropes and vasodilators. This is the typical donkey story, which everybody knows, and people used to talk about this. A preload, a tied donkey which is carrying the preload, and a slope that is the afterload, and a tide that is the where the weakened myocardium. So what will happen? You are going to give diuretics to reduce the preload, and giving vasodilators to reduce the afterload, and giving inotropes to enhance the stimulation of the myocardium. So all these are going to give some kind of additional benefit, reduction of preload, reduction of afterload, and increasing the contractility is going to be an important story. So what will happen? Fluid challenge. A patient is coming to the ICU with tachycardia, tachypnea. You don't have any modality of investigation there, no cardiologist available, and you are hesitant to do the echocardiogram. X-ray is awaited. So what we have to do is you have to give fluid challenge 5 to 10 ml per kilogram and see the heart rate response. If the heart rate is coming down with your fluid, that means the patient is improving and there is hypovolemia. If the heart rate is not improving, rather saturation is dropping, or baby is becoming worsening, that means it is a heart failure. This is a simple test you can do in bedside. So I am going to talk to diuretics. After that, I will stop it. So major role of diuretics are the class 1A indication. Any patient coming with respiratory distress, myocardial dysfunction, or non-myocardial dysfunction, the first modality of treatment is intravenous diuretics. Intravenous diuretics will give furosemide 1 to 2 milligram per kg IV, and if necessary, you please repeat it. Now, what we do is in the current practice, as soon as the patient comes with a big liver cardiomegaly, you bolus dose and start the infusion. This is very important here. Earlier, we also was giving only frequent boluses. Now you can, if you give too many boluses, it is going to be diuretic refractory. That's where infusions are very, very essential nowadays. On that, you can add spironolactone, and I'm going to tell you when to add chlorothiazide and other thiazide diuretics. During the treatment, over the period of time, there are 2 indications for thiazide diuretics. One is when you see diuretic therapy, loop diuretics are going to be refractory. Second, during the follow-up period, patient is on loop diuretics plus aldactone, then it is better to change over to thiazide diuretics. Otherwise, cachexia is going to be very problematic, and also electrolyte disturbance is going to be serious problem over the period of time. That's the reason cachexia is common in loop diuretics over the period of time. You have to check the periodic electrolyte monitoring during every visit on a strong diuretic therapy. Blood pressure checking and the combination of loop diuretics and potassium sparing diuretics are very, very essential. When you are giving AC inhibitors like enalapril or captopril in summer, it is better to avoid the potassium sparing diuretics because it is going to cause a serious problem of hyperkalemia. So avoid chronic diuretic therapy in children. So I will stop here. We'll take some questions and we'll probably.
Yes, sir. Yes, sir. Sir, are you audible? Am I audible?
Yeah, you are very much audible, sir.
Yeah. Sir, there is one question from one of the participants here, Dr. Isha Dayal. She is asking a question, what is the role of bedside ultrasonography for fluid responsiveness?
This is a very vital. That's what I was telling in the in between that, if you don't have echo or anything, whenever there is a patient, you have either simple ultrasound, not necessarily echocardiogram, check the inferior vena cava. If the inferior vena cava is full during expiration and inspiration, not collapsing, that means already it's a completely fluid. It is not a fluid dependent shock. It is a cardiogenic shock. If the IVC is collapsed or good response of inspiratory expiration, then there is a room for giving fluid. You can even give 20 ml per kilogram. So there is a collapsible index that you can read it, or I can share you. Patients who are on ventilation, there is a reverse collapsible index. We don't use that. So if you have ultrasound, it's a very, very good modality of point of care for giving the fluids.
Sir, can I proceed with another question?
Yes, yes.
Sir, what is the role? One of our postgraduate is asking a question, sir. What is the role of intravenous immunoglobulins in dilated cardiomyopathy, sir?
I'm going to show that slide. I intentionally put that one. I'm going to show that.
We'll postpone that question. Shall we postpone that question?
Yeah,
sir?
we'll postpone that.
Sir, there is one more question, sir. What is a prognosis if a dilated cardiomyopathy presents de novo, not necessarily due to viral myocarditis?
The dilated cardiomyopathy essentially in children are three types. One is viral myocarditis. Second is metabolic, any carnitine deficiency, so many other Pompe's disease, all this over the period of time will. Third is genetic. The genetic one is having a poor prognosis. Whereas dilated cardiomyopathy followed by viral myocarditis, fairly good prognosis if they respond to the modalities of treatment, identify very early and treat them properly. Whereas metabolic causes, some they respond, some they don't respond. So it's a variable prognosis based on the internal etiology, which still we need to understand that.
Sir, there is one more question, but I think it will be covered in the next session. Shall we proceed with the session, sir?
Yeah, okay. Thank you, Ajay.
Right, sir. Right, sir. Right.
So I am going to tell that aldactons antagonists, spironolactone are grossly underutilized medication. This is very, very important. Our practice is, even if I am giving AC inhibitors, I am going to add little bit of aldactone therapy. It has got proven that a combination of therapy is going to have ventricular remodeling. What will happen in viral myocarditis? The sarcomeres will be damaged. The ventricle is dilated. Whereas aldactone at the cellular level, molecular level, signal level, the remodeling will be taken place. That's why it is very, very important to add aldactone as much as possible, but make sure we are going to check the potassium very often. Inotropes, very crucial in the acute setting. I know that people now use aggressively dopamine, dopamine, norepinephrine, all this when you don't have any idea of what kind of shock, what kind of myocardial function, which is going to act on beta-2 receptors. Whereas the DIGOXIN, you all know the mechanisms very well. Sodium potassium pump and calcium will be available and on circa, so that excitation contractional mechanisms will be preserved and more calcium will be available so that the contractility will be enhanced. Levosimendan is a calcium sensitizer and which enhances the contractility of the cell. So now present people understood all this, but the practice, what is happening is when you give especially dopamine, it not only increases the contractility and to some extent it increases the PVR and also VG pressures. So that's the reason in cardiogenic shock, when there is a hypotension, lot of centers after understanding these mechanisms, they are switching over slowly to the adrenaline. I know that adrenaline will increase the SVR, adrenaline will increase the heart rate and also contractility. but the effect of PVR and capillary wedge pressure is much more worse than what it is. So that's why when I want to give dopamine, I'll give somewhat a little bit less dose of dopamine. When blood pressures are not maintained, then definitely adrenaline has got a major role. So these are all inotrope agents where it works. Alpha 1, beta, all this is available in the textbook. Let us not waste time on this. You all can read, and I am going to share all these slides to one of you. You can take it also. What is this? Anybody? What is this beautiful flower? Any answers came? So this is nothing but digitalis. So traditionally, people used to prescribe everywhere digoxin for ventricular septal defect, TAPVR, single ventricle, myocarditis, everywhere. Now we understood that digoxin has got very, very limited role, which is going to cause much more worse on a tired myocardium. But whenever there is a borderline myocardial function, or whenever you want to add other medication in a refractory case after diuretic therapy and vasodilator, which has got some role, which increases the cardiac contractility, reduces the ventricular end-diastolic pressure, and in younger, older children, it probably to some extent increases the exercise tolerance. That's why still digoxin has got a rule, but it is going to be class 2A and class 2B. That means 50% of the people believe that digoxin has got a role, 50% of people believe that it doesn't have any role. However, our practice is whenever there is a ventricular function, those who are not responding to the conventional medication of diuretics and vasodilator therapy, we are going to add at least 50% of the dose of prescribed dose of digoxin to all our children. Not necessarily we start as a first line medication, it is going to be third line medication in our hospital. This is going to be immediately first line medication as soon as we give diuretics in an acute decongestive state, acute cardiac failure. Milrinone is a wonderful medication. Believe me, I found very, very less side effects with this. Even you have a mean blood pressure around 40 millimeters of mercury in a 1-year baby, you can trust that giving the Milrinone, which directly it is an inhibitor of type 3 phosphodiuretase, and intracellular cyclic AMP will be increased so that L type of calcium channels will be open. So more calcium will be open to the sarcomeric reticuloplasm so that there will be inhibition. So the clinical effects we will see is improved cardiac index over the period of time, and it tremendously reduces the SVR. So what you can see clinically, I'm going to show you this particular slide now. So you see this arterial trace, which is called as constricted trace. Once you give Milrinone loading dose as well as maintenance dose, the trace will be widened. It will be like that. The delayed diastolic limb will be there. So the pulse pressure will be increased. Pulse pressure will be increased so that if you palpate the pulse, there will be bounding pulse. If I do the echocardiogram, aortic Doppler, there will be reversal of flow. So the phosphodiesterase inhibitors like Milrinone is a very, very versatile medication which reduces the afterload and which increases the cardiac index by several folds. These are all the dosages which are available. You can read it. So other medications like sodium nitroprusside, nitroglycerin are useful, but I'm going to just to show you slides. You can read that. Nitroglycerin recently we started in a child with a heart failure. I'm just checking the time. Sorry for that. So AC inhibitors has got a major role, especially captopril, which is not available, unfortunately. We are giving enalapril and lisinopril. Believe me, lisinopril has got more superior action than the enalapril. Children, grown-up children who has got some irritative cough, you can start a losartan on them rather than lisinopril. So these are all various trials which have shown that AC inhibitors are majorly useful, and we always start ACE inhibitors in the ICU setting after checking the creatinine, and we enhance the ACE inhibitors enalapril, and pre-discharge, it's a mandatory to check the creatinine again. These are all various studies shown that various age groups, infants, neonates and all, they got benefited with captopril and lisinopril. Now worldwide practice is to start straight away ACE inhibitors in children. So now recently we actually embarked on this medication called valsartan and sacubitril combination, but I am not going to recommend all of you to start this. We are giving a medication about 10 kilogram, about 2 years of age group, and we found very good medication in terms of improvement of the ejection fraction and the symptoms. We have more than 12 patients on this combination at this point of time. Beta blockers, we have got a great experience in treating the heart failure, and whenever there is no liver, that means liver is already regressed with the diuretic therapy, persistent of tachycardia. So any patient coming with heart failure, persistent of tachycardia, poor ventricular function, but no symptoms of congestive heart failure, like crepitation should not be there and the liver should not be there. These are the patients grossly benefited by the carvedilol, and usually you start with the 0.05 and increase to 0.25. Again, we start in ICU and admission. I don't start this medication in the OPD at all. Now you see, this is the one patient where congestive heart failure, tachycardia, and you can see after carvedilol, there's a significant response in this patient. So this is another patient to share with you from Paramita Hospital, a large ventricular septal defect here. We closed using a Konar MF device. Followed by that, child continues to have tachypnea here, continues to have tachypnea, heart failure, big heart. In this particular patient, we started carvedilol, and there was tremendous amount of improvement, and child comes for follow-up. So any patient coming with a heart failure, you can actually divide heart failure ejection fraction more than 40. If yes, start ACE inhibitors, and less than ACE inhibitors and beta blockers. If no, then you admit the patient if the ejection fraction less than 40 with the hypertension, tachycardia, respiratory distress, and check so electrolytes, BNP level, and then you start diuretic therapy. If the patient is in circulatory failure, then start inotropic support. I am going to show you roadmap. Now we start a medication called levosimendan. Levosimendan is a wonderful medication only in selected category. Don't start levosimendan for all with heart failure. Once you give diuretic therapy, inotropic support, and wait for the response for 12 to 24 hours. If there is no response and refractory shock, refractory heart failure, then there may be role of levosimendan. And now we embarked on levosimendan for the past 3 years. We have got experience on close to around 20 patients with around 60 to 70% results we are seeing. So this is a medication freely available, but you should admit the patient. You should see the diuretics and inotropic response. If there's no response, then only there's a role for treatment. This is the single center response France trial, which is showing that BNP levels are significantly reduced and ejection fraction, cardiac output also significantly improved, followed by treatment of the levosimendan. So now sometimes we are starting a medication called Ivabradine, which is freely available. This is initially from the extrapolation of data from the adults. Now we start in children with heart failure, not responding to beta blocker and persistent heart rate, which is higher. Then we start Ivabradine, and they will have good heart rate control, and the ejection fraction also will be improved. So this is what trial which I am going to tell you. This is the meta-analysis of the role of intravenous immunoglobulin therapy. This is close to 15 studies combined and then studied, which showed that there is no significant benefit by using intravenous immunoglobulin therapy to pediatric patients. So we don't practice it, even though my colleagues, somebody, they have shown a lot of interest in doing that, I really don't believe at this point of time giving intravenous gamma globulin based on the scientific evidence. This is the patient with acute ventricular dysfunction. You can see there's a blood clot here. Can you see that? And this child is highly potential susceptible for the CVA. This boy, we actually admitted, given inotropes, diuretics, and levosimendan and oral anticoagulants. And you see the response immediately, child improved tremendously very well. So the important message I want to tell you is ventricular dysfunction, presence of less than 40%, you have to give oral, you have to give intravenous anticoagulant medications. This you have to take a serious decision. So whenever you have a patient with a heart failure, start diuretic therapy, pulsed diuretic therapy, then intravenous infusion, then you switch over to oral combination medication and start AC inhibitors, then start after 48 hours, once the congestive symptoms improves, beta blockers, then during the follow-up, you please add aldosterone. Don't forget about that. Usually it falls after 1 week after the treatment. So anybody would like to comment on this X-ray? I'm going to open the chat box. I'm going to have the interaction from here. Anybody would like to tell this ECG? You see the ECG? I have never seen such a kind of tall P waves. T waves. I'm sorry, T waves. You see such a tall T waves. One of my colleagues, Dr. Shweta, actually she suspected, she read somewhere that when you have such a kind of a giant T waves, it's a feature of carnitine deficiency. This is the second case which I have seen that carnitine deficiency, and this patient we evaluated all levels of carnitine, acyl carnitine profile, free carnitine, everything became very, very low. Child is on follow-up with the treatment. We started on carnitine treatment from Nizamabad and he is doing well as of now. This is another modality of treatment. We embarked on that when I was at Care Hospital. When you have a normal synchronization, you will have like this. When myocardial dysfunction and left bundle branch block or intraventricular conduction block, then you need to put a CRTD. Here you can see the ventricular problem is there, conduction disturbance, LBB, and after putting the device, and it is going to be narrow QRS. Those patients really, they improve. This is one of the patient with, we have to give his bundle pacing here, and his ventricular function improved very well. So another, this is the his bundle pacing which we did and improved very well. So sometimes we do surgeries. This is another patient. Actually, you can see this ventricular significant MR here with LV dysfunction. We had to do mitral valve repair surgery and child symptomatically became very better. There's one of my senior colleague from Germany, Dietmar Schwarz, Professor Dietmar Schwarz, very close to me. We were co-speakers in several meetings. Wonderful person. He has done a lot of work on heart failure, PAH, and he found that banding of pulmonary artery is going to cause a shifting of the septum towards the left ventricle. But we have not done this. Still, it's an investigational process. We need to have a cardiac transplantation program to do this kind of procedure. Now, people embarked on ECMO, ventricular assist device, all these are available. We got an opportunity to do ventricular assist device to one patient. We got the device, but the patient died by the time we prepared the patient for the device, ventricular assist device. This one patient, we had a bridge to give ECMO for the severe fulminant myocarditis and refractory VT-VF, and child improved very well with this and doing very well. Cardiac transplantation in India, especially Bala group from Chennai, All India Institute of Medical Sciences, they are doing in children and also some in Bombay in children. This is the data thanks to Dr. Ganapati who shared the data to me. And these are the children with dilated cardiomyopathy. Other categories are doing very well. This is another case of ventricular dysfunction listed for transplant. I had to send them to Chennai for the LVOT resection, keeping the case for the ventricular, keeping the case for the cardiac transplantation. You see that LVOT resection was done, ventricular function improved, normal, child became normal. So let us don't think that transplant is a final treatment. It is another new disease which we are going to buy with a lot of money. So this is going to be very important slide. So whenever you have a patient comes, so first start inotropes, give IV diuretics, vasodilator therapy, and correct anemia with the PRBC. And if they don't improve, escalate the medication, multiple inotropes, levosimendan, invasive ventilation, mechanical circulatory support, all this will come here. If they don't improve, probably that is the time we should think about the transplant. If they improve, uptitrate the AC inhibitors, commence oral beta blocker in 3 to 1 week time, 3 days to 1 week time, and wean off the diuretic therapy and rehabilitate time. Over the period of time in the OPD, convert to oral medication, optimize the AC inhibitors, and then switch over to oral anticoagulation. So just going to stop here. This is a Al-Kappa patient, needs surgery. There is no role for the medical treatment. Just a couple of slides. This is a ventricular dysfunction case due to severe aortic stenosis in an infant and potentially treatable with the balloon. And this is, you all know that shivering heart, tachycardia, cardiomyopathy, several cases we see. Every meeting we present these kind of cases. You can see here, it is a pre-excitation present and child improved immediately after the medication. That's the atrial tachycardia. I'm really sorry for that mistake. So other collaterals, that is quite common, refractory heart failure. This is what I want to emphasize this slide. We started genetic clinic now, and we are doing varieties of observations. And this is a paper which is manuscript is ready during COVID. Thanks to COVID, it made us to write a lot of papers. And this is where genetic clinic plays a major role. And we are in the process of doing several of these things. So several recent advances changed the clinical practice of patients with a heart failure. Extrapolation of data from adult population is useful, but now there are a lot of RCT trials are available in children. I believe that optimization of treatment is necessary to all patients based on their clinical response. That is where it is going to be a challenge. Thank you very much. I am sorry I exceeded time. Initially, I thought 20 minutes. Dr. Bhaskar said 45 minutes to 1 hour. Then I thought 30 minutes. Then eventually it became 1 hour. I am really sorry for that. I would like to take some questions if time permits.
Dr. Ajay Mohan. There is a question from one of the doctors. Am I audible?
You are audible, sir, but Ajay microphone is muted. If you can.
Okay, I will unmute his audio. Sure. I will unmute.
Yeah, yes, sir. Am I audible, sir, now?
Yeah, you are audible. I am sorry, Dr. Ajay, for taking time.
No, sir. It was a wonderful class, sir. It was a wonderful class, sir. Sir, there is one question from one of the participants. Hello?
Yeah, I can hear you very nicely. Again, your microphone is mute. It's good to unmute that. Please unmute your microphone. Bhaskar sir, can you unmute Dr. Ajay's microphone? Bhaskar sir, can you please unmute Dr. Ajay's microphone?
Sure.
Yeah, now it's okay, sir.
Yeah, good.
Yeah. Now, there is one question from one of the audience participants, sir. Is central line mandatory to infuse Milrinone? Can it be used in a busy PICU without pediatric cardiologist services?
Yeah, I took that question, but I can't hear you the second part of the question, but it is a very important question. What will happen when you have a central line? You as soon as child comes, you are going to chase the patient of the lines, everything. I agreed very clearly. Whenever there is a circulatory failure, your peripheral lines will not work. It's better to go for the femoral vein rather than the jugular vein. What will happen? Jugular vein, and you put the central line, it sometimes irritates the SA node as well. And sometimes it may be thrombogenic. If you can get the femoral venous line, it's very good in an acute circulatory failure state. But for the Milrinone therapy, inotropic therapy, not necessarily you should have central line. If you have a wide bore peripheral line, 22 or 20 in grown-up children, Milrinone can be given easily. But for your assessment of pharmacological response, clinical response, if you have a arterial line, you can check the blood pressure, you can see the waveform, whether it is constricted or dilated. Even you can palpate with the pulse also, or you can do the echocardiogram to see the diastolic reversal. So all these methods can be done. It is not mandatory to have the central line when you are giving your Milrinone.
Sir, sir, there is one more question. Is there a role of ACE inhibitor in acute myocarditis? And is there a synergy with an inodilator like Milrinone?
So the practice and how you have to manage an acute myocarditis. Child coming with you, tachycardia and gallop, there is a liver and crepitations are there. IVC is showing congestion. You have given already diuretic therapy. You started inotropes. Your BP is above 40, mean BP in 1 year above 40. That is a very, very good case. If there is a tachycardia, peripheries are cold, BP is good, you start Milrinone. AC inhibitors have got no major role in the acute setting. If you give AC inhibitors, it is going to cause more harm and more danger because you don't have knowledge about the renal perfusion, you don't have knowledge about the how much of blood pressure response is going to be with your single dose of AC inhibitors. Generally, they will have first dose response. As soon as you give, you can immediately BP can fall. You cannot revert it because whereas Milrinone, you can abruptly stop it and you can increase the inotropic support. So that is the reason first line of treatment is Milrinone, and after 24 hours, 48 hours, then only you have to start AC inhibitors. You should never start as a first line medication as soon as patient comes giving AC inhibitors is totally going to cause harm to the child.
Sir, there is one more question from one of the participants, sir. Hello? Hello, am I audible?
Yeah, you please go.
Sir,
yeah, you are very much audible.
Yes, sir. There is one more question from one of the participants. Very interesting question, sir. This is, inotropes are supposed to have tachyphylaxis, but sometimes child will require it for more than 5 days. What is your opinion on this tachyphylaxis in vivo, sir?
Absolutely correct. If you give prolonged inotropic support, it is going to cause the refractory. When you have refractory treatment, refractory like dopamine you are giving or dobutamine you are giving, if you don't add additional medications, by the time already you have to give vasodilator therapy and the AC inhibitor. If you don't wean off the inotropes for over the period of time, it is going to cause a tachyphylaxis and refractory. So that is the reason in case of refractory or tachyphylaxis inotropes, you change over the different inotropes or add levosimendan after 3 days of the inotropes when you feel it is going to be refractory, then it is useful. Either you change the inotropic different kind, or you add levosimendan, or change over to additional medications like AC inhibitors and beta blockers by that time. Otherwise, more than 5 days, I totally agree with you. It is going to cause a refractoriness to the inotropic medication.
Excellent, sir. Sir, there is one more question. What's the role of an anticoagulant in a heart failure?
It is very essential. We were also very skeptical sometimes, and sometimes we overlook and we don't give anticoagulants. Any ejection fraction lesser than 30%, you have to give oral anticoagulants. Otherwise, they will present with CVA, strokes. We have 5% of the children presenting with CVA, hemiplegia. Recently, the last patient came from Vijayawada with a hemiplegia, with a big LV clot. We treated them, improved very well. So it's a mandatory to give. During follow-up, if you have ejection fraction more than 30% and lesser than 45%, you give aspirin. That is going to be very useful. Otherwise, you have to give oral anticoagulants for all patients with a low ejection fraction. They will develop CVA.
Yes. Sir, there is one more very your comment from one of our very senior pediatricians, sir. Yes, sir, your special
maybe you can tell the name of the pediatrician.
Dr. Lakshman Kumar, sir.
Yeah.
He is asking one question. Your comment on hypocalcemic myocardiopathy.
Lakshman, this is a wonderful question. I am telling you, we have seen more than 10 cases of hypocalcemic myocarditis. So that's why as soon as child comes, three important investigations we do: hemogram, electrolytes includes calcium and magnesium, and then serum creatinine. If the calcium is low, we have to treat that. The previous question you asked, tachyphylaxis and refractoriness to the inotropes. When you suspect tachyphylaxis and refractoriness to the inotropes, calcium infusion is going to be, add calcium infusion, which is going to be very, very useful in this setting. I have forgotten to tell that. Since Dr. Lakshman brought that question and comment, I appreciate him. This is very, very important. We treated, and believe me, they all become normal. Whenever there is a hypocalcemia, ventricular dysfunction, they are all going to be normal. So if I forgot in my talk, please add that calcium assessment is mandatory for all patients with myocarditis. Thank you, Dr. Lakshman.
Sir, a question from my side, sir. One question. What is your opinion about this Batista operation that is, which we usually see? I mean, we don't see it, at least in India. I don't know whether it is performed in India, about the left ventricular.
Batista operation originally described by, Batista operation originally described by Brazilian surgeon called Dr. Batista. They used to call bench Batista. You take the heart and cut the dead myocardium and then suture it and then put it back. So these are all called as ventricular remodeling surgeries. The method, what he has done originally, gave a basic principle to do the ventricular remodeling surgeries. Now, nobody practiced that Batista operation, but it gave a solid principle that various operations like now transcatheter, parachute, ventricular remodeling surgeries, mitral valve repairs, all these fundamentally came from that. So it has got a fundamental principle idea, but nobody practiced that surgery right now.
Okay. Sir, last question, because you are asking about, you are telling about the genetics in heart failure. Can you just leave a few comments on this treatment targeting caspase enzymes and the anti-apoptotic BCL2 gene therapy, sir? Genes.
See, whatever I want to tell you that we have got 14 families with various genetic abnormalities. You try whatever it is going to be very difficult to treat these genetic abnormalities as of now. The only thing which is useful is if you identify the problem, at least subsequent pregnancies, you can do either donor egg, donor sperm, and then identify the person and then do it as of now. But in future, I am going to agree with you, it is going to be a major modality of treatment. But at this point of time, we do TMS for all to rule out a rare disorder like a thiamine, niacin deficiency. All this we work up as a part of that. It is very cheap test also. And if there is once in a while, you may find one abnormality and then you can treat it.
Sir, sir, one last down now. We will seal the entire session with this last question.
There's no problem. From my side, I can take any questions. From other side, you please think their side. And
yes, sir. Yes, sir. Yes, sir. Now, this is a question from our own IAPTCB. I think RSV is Sri Krishna is asking this, sir. What could you link this COVID-19 with CHD? Is there any myocarditis or any other heart abnormalities in this COVID-19 season?
Actually, it is a very pertinent question for this context. Coronavirus can affect heart with structural heart disease, with no structural heart disease. With structural heart disease means either post-operative or native heart like VST, small VST, unoperated tetralogy of Fallot, or post-Jennings. So those cases we treat like a regular coronavirus infection and treat them. There are so many guidelines came. Now the problem is overlapping of two entities. One is coronavirus, which is involving the normal heart, produces two types of problems. One is myopericarditis, second is Kawasaki-like syndrome. Now, several papers, case reports, predominantly case reports, including my Italian group. I am working very closely with the Epicenter Barmago Italian group because those guys trained under me in January to February. As soon as they left from India, our center, they actually started working in Italy, the same center. They all doctors got COVID and they produced the data. So now more number of Kawasaki-like illness are coming, followed by the epidemic of COVID. That I believe is immune modulated, like a Kawasaki-like syndrome is coming. Second, during the epidemic, you may anticipate, you may see myopericarditis, but it is going to be behave like dengue fever or dengue myocarditis syndrome. So even we don't have knowledge unless Gandhi people or government ask us to go and to see the children in Gandhi hospital. I am not in a position to tell the actual what is happening to all these conditions.
Thank you so much, Dr. Sri Krishna here.
Thank you.
I mean, questions will keep on coming as long as you're there to answer. I'll give Dr. Ajay Mohan a breather. Hopefully the last question of the night. Which AC inhibitor do you prefer for afterload reduction in children with rheumatic MR or AR?
That's a very good question. I prefer personally lisinopril is my favorite AC inhibitors. There is nothing like a favorite like a Paradise biryani or some other biryani which you hear. What I mean is, what is the clinical response you observed over the period of time? My observation with the AC inhibitors, captopril used to be tremendously very good, which is not available. It is waste to discuss about that medicine. Now, three medications you can trust really. One is lisinopril. The second is bisoprolol. Bisoprolol we are not, that is different. Then valsartan and enalapril. Enalapril, lisinopril and valsartan. These three are very good, but ventricular dysfunction about 2 years, about 10 kilograms, we are starting valsartan. But by and large, most of the patients, including this subset, we are giving only lisinopril in our practice. But a lot of people, they give enalapril. I am not against of that.
Thank you, sir. Anyone, Dr. Vijay Shekhar, Dr. Lakshman, Dr. Vijay Kumar from Warangal, thankful to you, all of you for participating in the webinar from IAPTCB. Any one of you who would like to make a comment or just would like to wish Dr. Nageswar, please lift your hand so that I can then unmute you. Dr. Lakshman Kumar?
I am seeing Vijay Shekhar sir. Good evening. He is lifting hand. And Lakshmi
just give me a minute, sir. Dr. Vijay Shekhar, you're unmuted. A quick comment and a good night from your end to Dr. Nageswar.
Sir, only one question. Have you had any personal experience with cardiac transplantation in your dilated cardiomyopathies?
Yeah, we have actually referred 4 patients for cardiac transplant to Dr. Balakrishna, Chennai, because we don't do that work here. It is good idea to have regional centers rather than every hospital tell that I do transplant. It's not a good idea. When you have closest, you send them. So 4 patients we send, of which 2 patients died. And 2 patients, one is doing very well. Second patient is under follow-up with them. They're having a heart failure still to some extent with the medications. So the pediatric transplant program shown that 70% are having 60% to 70% 10-year survival rate is very good.
When should we, in our course of disease, think about a cardiac transplant? Is it if they are going into cardiac failure again and again, or is it that there is a steady deterioration of ejection fraction?
Yeah, there is refractoriness to treatment and recurrent admissions. There is a further grading of the heart failure in ICU patients called Intermax classification, class 1, 2, 3, 4. So whether they will be benefited or not benefited, like presence of low BP, then renal perfusion is, creatinine clearance is less, all that parameters, I am not working on that. So based on that, they will take a decision whether to transplant or not. If you ask me, I am not that kind of a favor towards to send for the transplant. Try to manage as much as possible in the first decade. Beyond first decade, if they reach towards to adult state, like you have 25 kilogram weight, then you think about a VAD, ventricular assist divide. That will be, there are 2 types. One is BTT, second is DT. BTT means bridge to transplant. DT means destination therapy. Bridge to transplant will be given to elderly, those who cannot tolerate anything. DT is good. That is destination therapy. You give the VAD and let them live for long time. Now results are coming with destination therapy. They are going to live with the VAD for long time. That is my principle. Rather than doing a lot of cardiac biopsies, medications, because Indian setting, fungal infections, rejections are very common. I am worried more of that, not that I am pessimistic and all.
Yeah. Thank you, Dr. Vijay Shekhar. Dr. Lakshman Kumar.
Yeah, thank you, Nageswar garu, for a wonderful talk from Karimnagar. So congratulations. Only one question is, now COVID-19 epidemic is going on. Do you think that the congenital heart disease children will have same the prognosis of adult with the heart disease?
No, sir. The congenital heart disease patients are somewhat higher risk compared to the normal children. That's why we send a lot of information to all registered patients in our hospital, and we did video counseling also. They have to take more special care. That means to prevent itself. Once they get COVID infection, I believe 2 patients died in the periphery. I am thinking those patients are COVID, but none of the patients came to us with features of COVID. But the Italian data showed that these patients are much sicker, and if they go on to ventilator, weaning off from the ventilator in an untreated, uncorrected congenital heart disease is going to be very challenging, and morbidity is very high. So that's why they are more higher risk than compared to the normal children.
Thank you, Dr. Nageswar. Thank you, Dr. Lakshman, Dr. Vijay Shekhar, and all the senior IAP members, as well as the full house today. Closing remarks from Dr. C.N. Reddy and vote of thanks from Dr. Bhaskar. Dr. C.N. Reddy, please.
Okay, good evening, all of you. Wonderful and excellent lecture, very much informative. And we learned a lot of things and a lot of treatment, lot of new medicines in recent advances in the treatment of congestive heart failure. And thank you very much. We enjoy your lecture, Dr. Nageswar Garu.
Thank you.
Really, you are doing a lot of work in pediatric cardiology. You are doing research, clinical studies, and whatnot. Or you are doing. We are hats up to you, and we are proud of you. Thank you. I will hand over to Bhaskar. Tomorrow's program and vote of thanks by Dr. Sankoj Bhaskar.
Thank you, Dr. Nageswar, for your excellent presentation. It's always your lecture is always a music to the ears. You make the complicated topics, complex topics, very simple, easily understandable. I'm sure all the participants had benefited from your brilliant talk. As Dr. C.N. Reddy said, we are really proud of you, and you made Hyderabad proud because it is there on the map of the world, on the pediatric cardiology map of the world. We are really proud of you, like we were proud of Dr. Reddy of Dr. Reddy Labs. So hats up to you. I sincerely thank you for sparing your valuable time. And the attendance for this webinar is the maximum. It is around 140 to 150. And people are eager to listen to you even for another 30-40 minutes. That is your specialty. My sincere thanks to you. Hope to have your presentations in near future again and again. I thank all the participants. Thank you one and all. And tomorrow same time, that is at 8 p.m., we have a topic on neonatal jaundice evaluation and management, and followed by Dr. Ravi Shankar, a senior neonatologist from Soumya Children's Hospital. Thank you once again.
Thank you. Thank you.
I thank my colleagues, Dr. Ajay, Sri Krishna, and my president, Dr. C.N. Reddy. Thank you very much.
Yeah,
good night.
Thanks everyone. Make sure you are pressing on the leave meeting before you exit. The app will run in the background, so make sure you exit the meeting. And my apologies if you've been in the waiting room. That's part of the security process, and hope you had a very nice learning experience tonight. That's all from our end, and I'm ending the meeting now. Thank you.
Yeah, thank you.